Morning, everybody. Good morning, everybody. Good morning, I said. That's it. Please sit down so that we can start off the first session of this morning. It's the second morning of Sham, and I'll call to the round table for a debate concerning connection all over France from the patient's home to University Hospital. Philippe Domy, Olivier Guérin, Stéphane Regnault, Sébastien Robineau, Pierre Simon, and the debate will be led by Jean-Daniel Flézaquier. Good morning, everybody, and thank you for having been courageous and got up so early in the morning. We're going to spend 45 minutes discussing a subject that may be a little bit redundant in view of all the brilliant communications you heard yesterday, so I'll try and make sure that we avoid repetition if possible, and we'll see if we can achieve that. First of all, we'll start off with the traditional video, which is going to set the scene for the debate. Auvergne 2023. In his little house just outside the village, Archibald, 75, is having a coffee as he does every morning, when suddenly he passes out. Seeing that he hasn't communicated at 10 as usual, Nestor, his domestic robot, warns the emergency department. SAMU team is immediately sent to Archibald's house, and his life is saved by dissolving the blood clot at the University Hospital in Clermont-Ferrand. In olden days, people used to say that there was a doctor in each constituency of France, but those days are over. Isolated areas, medical deserts. Soon kilometers will be less important than microbits. Being elderly with a chronic disease and living in the middle of nowhere without a doctor within reach and over 80 kilometers from the nearest hospital will no longer be a problem. If you're connected. For the health professionals, it's also a revolution. The HPST law has set up a legal framework for telemedicine, and priorities have been identified on national scale, such as the telestroke experiment deployed in several regions. The principle: 24 hours a day and 7 days a week, a neurologist and a radiologist are on call, ready to give their opinion to the emergency staff of the hospitals who need advice. This is what is known as tele-expertise. Remote surveillance to prevent emergency hospitalization is all just as promising. Jeanne, for example, is one of Dr. Tournesol's diabetic patients. Thanks to the medical devices in her home, her doctor can monitor the changes in her blood sugar levels and define a threshold. New uses to save more lives? Yes, of course, but not just that. By avoiding superfluous hospitalization and betting everything on the new technologies of the future, the promise is also an economic one, in all the senses of the term. But not only that, by avoiding superfluous hospitalization, we'll be saving money. Well, apart from the spectacular side of that, we'll have to come back to reality. We heard yesterday a lot of very relevant things, and I'd like us to take stock of the situation with you, Pierre Simon, because you're the chairman of the French Society for Telemedicine. What are the validated indications, or the ones that we think could be validated for telemedicine? Is the fact that you're over 70 and living 20 kilometers away from doctor mean that you're going to have sensors on your head all the time? Or are there other reasons to be connected up? Well, telemedicine is one of the things that France has been a pioneer in, because it's been around for 20 years now. And we're now capitalizing on the experience that have been carried out in different parts of France. One of the priorities for telemedicine today is something that we defined in 2011. That is to say, improving the diagnosis on imaging and in chronic diseases. In terms of epidemiology, we have a critical mass of patients now who have heart failure and renal failure and are diabetic. And these are the main indications, especially for diabetes, in which we are trying to set up systems, because a lot of the people who are sent to hospital don't really need to go there, and we could prevent that.
In many other areas, we're running 10 years late on other people. Are things working? Are we preparing new things for the future? Or are things stagnant? Well, I said we were pioneers because there were two pioneering countries in Europe, and that was Norway and France. Why are things slowed down today? Well, I think it's mainly due to funding. Funding telemedicine is something that we need to identify with more clarity, especially in the hospitals and in our private system. There's also an offer. Maybe I should turn to the representatives of the Medical Technology Syndicate. I think proposals are coming in from all sides for equipment, sensors, and so on for telemedicine. As far as the devices are concerned, we're no longer in the starting box. These devices actually exist in many different sectors, and they've proven their effectiveness. Many studies have been carried out. I'm thinking about telecardiology, for example, proving that to start with, it works, and secondly, it saves money. We're in an environment where we have constraints in terms of the funding, and I think it's urgent to set up systems that can help us to save money. You must remember that the first main client of the taxi system in France is the social security system, because every month you go to see your cardiologist or another specialist, and you take a taxi to go to the hospital and come back, and that's going to immobilize the taxi for the day. And that has a social cost because it means a day off work. So these things do exist, but what doesn't exist is what we pay for and why. Have we done any real medical analysis to see whether we are actually cost effective or not? Or are you just bringing out a sort of little toy, and since everybody's interested in playing around with it, they want one? Seriously speaking, it's very difficult to have people who are really capable of assessing these tools to talk to. In the health system, everything is very vertical. We don't actually integrate the patient's health trajectory. And you think that we need to have an Emmanuel at the health portfolio? Well, don't get me saying things I shouldn't be saying. Let me just say something unpleasant. These little apparatuses are medical devices, so they're marked with a CE logo. This sounds like a stupid question, but let's take the example of PIP prosthesis. I'm not talking about the actual court case. I'm talking about the company that manufactured. Can you really stay with the regulations that have been demonstrated to be so ineffective for medical devices? Well, the whole profession is waiting for a reform of the CE logo to make sure that the logo really does mean quality, because a lot has already been done, both before and after the PIP case, and new reforms are underway as well. People are expecting that. But no profession is going to be sheltered from this sort of problem. A con man can always come along at any time, and sometimes even the police are unable to spot them. But we're going to do everything we can to avoid this sort of problem. Well, that's really not the problem. It's the people who give the logo and are not demanding enough. In terms of telemedicine, there's been so much experimenting for so many years to test things. And I think we've got to extend the experimenting to the national level. With the years of experiments we have behind us, I can tell you that many of these devices have been validated many times. Right. Well, as far as data sources are concerned, we have the patient who sees his doctor and the data collected by the hospital. Who does the data belong to? Does it belong to the patient, the GP, the hospital, or is there sort of co-ownership of this data? Olivier, you're a geriatric specialist. You probably have your opinion on that. Well, that's a legal issue, of course, but we've already debated on that subject several times yesterday. What I'm really interested in is how to use the data in the patient's best interest. And I think we've got to get back to something simple here. A lot of geriatricians are involved in this sort of issue. We're at the end of the chain as geriatric specialists, and our old elderly patients, the most vulnerable ones, the ones that have multiple disorders and we find that they're really out of luck in many cases because they get to hospital too late. They've not been monitored properly for their pathology. We get them when they're totally decompensated and we can't do anything for them. We try and make them self-reliant again so that they can have a good quality of life. But when we start off on the basis of this, we've got to find a way of reorganizing this health system completely to respond to a need that just isn't covered right now. Chronic disorders account for 70% of the health expenditure. We have a model which is based on curative medicine and which is just not adapted. So we're not good. When you see how the elderly are relatively badly dealt with in a certain number of hospitals. They may have to stay as long as 24 hours or 36 hours in the A&E. What do you think we ought to do? I really don't know. Well, we try and manage them as well as possible. But we've got to give the geriatric department more means to do it, to the detriment of other disciplines, of course, but don't say that to my colleagues. There's a big movement at the moment to try and restructure the hospitals, but the geriatric department is probably not even concerned. We are always going to need hospital beds. We're already... But the fact that you're monitored at home, how is this going to mean that the patient is better managed in hospital because they'll be managed at a later time? Yes, of course. It's the whole point is when you've got an elderly patient, you've got to try and avoid them decompensating. We've got somebody who's got heart failure. As soon as they get into hospital, they're dealt with. But the whole point is that we want them to go to hospital as little as possible whilst avoiding them decompensating. If we'd been able to locate the fact that that patient was gaining weight, when you're a heart patient and you gain weight, it's usually that you're storing water. And when that gets to the lungs, you get pulmonary edema. And once you get to a pulmonary edema stage, you become blue and you can't breathe anymore. You've got to avoid that stage. If you have a connected pair of scales at home and you've got an emergency doctor who is effectively trained and can work with a nurse at home to give you some diuretics, then you can avoid that situation. I think we've got to put things into the right order. First and foremost, concerning hospital in general and the university hospitals, and I endorse the the video that we saw. The whole point is that you've got to manage the situation in which you only go to hospital if it's really strictly necessary. That's got to be the founding principle of the use of hospitals in our health system. Having said that, why are we going through all these problems that you've just quoted? For a simple reason, because in hospital, we're not living in the nice world of teddy bears we described yesterday. With the general enthusiasm we heard yesterday, because everybody applauded, things are accelerating and everything becomes possible. And it's going to happen, except that in real life, because you've got to think about what does happen in real life. In hospitals, we are faced with reality, and that's not what actually happens. Are all the conditions fulfilled with the information systems we have in the hospitals today to include these connected objects? No, far from it. How many hospitals today, both the public and private hospitals, are capable of actually pinpointing a patient file which is electronic and has all these functionalities with prescriptions, imaging, online appointments, and test results, and deploying all these different things? You'd be very surprised if you saw the results. Actually, we're living in a cloud, except that when you've got your hands in motor oil and your feet in the mud, things are very, very different. And it's not simple at all to be consistent in the public hospitals, and it's very difficult to be coherent when you've got the public and the private sector to deal with. We saw at the TSL competition. What is the TSN competition? Well, it's the digital care in France campaign. We asked the ARS to carry this project, which wasn't theirs to start with. And rather than talking directly to the operators who took the initiative and had the relevant level of information, they did otherwise. So there are many things to deal with. So let's go through this in the right order. First of all, we've got to create the infrastructure, because to develop all these connections, you need the infrastructure. And the infrastructure is on grassroots level today. And everybody's complaining that we're lacking means in the investment projects, which are extremely costly. We don't have enough software. And we've got to get ourselves out of this rut. And because the market allows us to do that, we've got to purchase the services we need. We've got to buy infrastructure. We've got to buy software, which will enable the hospitals to deal with their problem, because everything's becoming obsolete. And when you've got an information system that works more or less, then the next thing that happens is that either the software or the hardware needs renewing. So the operators have to be in tune with those challenges. And then we've got to stop quarreling, because it really does pollute the atmosphere. I'm at the end of my career, but I could say that wherever I went during my career, I always saw the general hospitals being extremely defiant vis-à-vis the university hospitals, and selecting a different IT system, and they can never communicate. So to deal with the problems of the geriatric departments, which are really necessary today with mobile teams, internal systems that can be used in psychiatric wards and so on, you need an effective internal information system that communicates with the heterogeneous external systems of the GP and the specialists and the paramedics and the health insurance system. We've got to create the conditions to interconnect these different systems. And today the technology exists. And we've got it. It's close at hand.
There are political solutions. Yesterday we saw that we mustn't count on these and we have to count on ourselves. You know, it's always better to do things yourself, so we're going to do that. But here again, there's going to be a fantastic opportunity with area hospital groups. Let's not spoil that opportunity. We're going to have the opportunity, the luck, once and for all, to coordinate these information systems. That doesn't mean to say the same information system for everybody, but there won't be the development of information systems that is... So we need something that communicates and brings people together. So we have the technical components for this to work. General physicians have their role to play. Specialists have their role to play. Hospitals have their role to play. Being able to communicate, being able to share the information, share the patient's medical record, allows cardiologists to consult the geriatrician to communicate immediately with the coordinating doctor of the retirement home or the general practitioner. So, you know, that's all we need. Now, so there is going to be an influx of data. Is there going to be enough? Are there going to be enough people, doctors, medical personnel, to deal with all of that data? Let me show you this. This is a personal file. I went to a university hospital in the center region, and I went to do that, to record my heart. And that was in March, and I received a letter saying that everything was fine in August. I live 3 kilometers away from the hospital. So, you know, this is how it happened. So this is the proof. I have it in my hand. Now, with telemedicine, and it was a normal recording, right? It's not a question of telemedicine, that, though. It's a question of the information system performance. You know, you've got the anesthesiologist's reports, whether you're having an operation, whether you're waking up from an operation, whether you're being examined. As long as everything is plugged in, everything is connected, and the examination is in the patient's record, and in real time, everybody can access the patient's record, including the patient first and foremost, then you don't have that kind of problem happening. But there are solutions today. Perhaps we need to explain that you don't need to put a stamp on this kind of letter as well. No, what I mean in relation to telemedicine is that telemedicine is not a solution to the lack of doctors. For telemedicine to work, you need a doctor. Otherwise, there's no expertise that exists. And we're getting everything wrong with respect to the product. This is what Nicolas Bouzia was saying yesterday. The more technologies there are, the more people you need. So since the beginning, we've talked about the role of the general practitioner. You're a general practitioner, and you're the co-founder of a startup called Santé, Sébastien Pinault. Today, do you have the impression that family doctors are ready to play that role and use the equipment properly? How are they going? I mean, they don't want to feel dispossessed of their role of doctor with their patients. How are we going to prevent that from happening? So there are 2 questions. There are 2 questions there. I see 2 questions. Let me start with the first one. So there is an enormous gap between this happy-chappy world presented in the film and what you've told us with the example of your letter. Today, in terms of primary care, with were not able to absorb information from the hospital, receiving reports from the hospital in ordinary GP surgeries. Now, I wasn't even informed of my own results, neither was my GP. And that's not good. That's not good. So there's a huge gap there. I realized that in my everyday practice. So we needed to invent new systems. We knew this to allow doctors. So, we have asked doctors whether they're ready. Yes, they're ready mentally, but they don't have the tools to be able to work properly. A surgery today, as it's organized, well, you've got to realize how it's organized. 25% of surgeries in France don't even have an IT system. They still use paper. Some of you, will have little sheets of paper that the doctor uses. It's the reality of the situations. Some even say 50%. Well, yes, you have perhaps more up-to-date data. But this is a reality. So we have to start by doing simple things. A doctor today in their surgery spends half of their time doing things other than medicine itself, managing the carte vitale, patient card, and that time that is not used with consultations, well, it means that they can see less patients. So if we can reorganize primary care by providing doctors with the resources so that they can focus more on their patients, then, of course, we have accessibility again. Accessibility, it's not just a question of increasing the number of doctors, but doctors can't do that on their own because they are doctors. They're not IT specialists. They're not organizational experts. And that's why we said to ourselves that it would be a good idea to create a tool, a kind of matrix, a surgery that would act as a laboratory in order to allow all of these healthcare professionals, we're talking about patients, doctors, hospitals, university people, to connect up to a matrix or a grid that would use data, that would collect data so that they could be more efficient. So this is one of the main obstacles that we have today. We've talked about financial obstacles. We've talked about political obstacles. Nicolas Bouzier was talking about the precautionary principle, where we're rather cautious. There are some simple things that we can do, but we need to experiment with them. And especially in France, we're very good at experimenting with things. We're even ahead of the time. We invented the Minitel. I don't know where the Minitel has disappeared to, but I don't think we use it anymore. Unfortunately, says the moderator, 3615 was the special number. So basically, the idea is to move on to the next stage. Give back power to people in the field so that they are leaders and provide them with tools. There's no point creating tools that serve no useful purpose. We talked about the EMR yesterday. There are many tools that are not used. Let me just ask another question. Perhaps it doesn't correspond to reality. Let's imagine that I'm a connected patient. I've got my data, my GP has them, my specialist, my cardiologist, etc. Now, do I say to myself, why bother going to see my GP if I've got a problem? Because I've got the specialist there who knows everything in the same way. Is there not a risk there? The patient will be playing an accessory role because of telemedicine. Right, I'm going to preach what I believe. We're talking about specialities in general medicine today. There's a primary care specialist and there's an organ specialist. There's a difference between the two. In terms of education, that's a notion that we are promoting. I can see that you're looking not convinced. Anyway, there's an awful lot of educational focus on this difference. And we've got tools, we've got projects to underline that difference. Now, the question is, what about GPs? Are they going to be replaced by all of these tools? Well, I don't think so. I think it's quite the opposite. The doctor is an essential filter as long as they have the right tools to do this properly. Laurent Alexandre last year said, in rather an excessive and passionate manner, that at the end of the day, if we don't take the train while it's moving, algorithms will replace GPs. If we're not careful in the future, specialities may disappear, but these will not be general medicine specialities. There will be hyper specialities. It's easier to build an algorithm for a specialized cardiologist for a certain patient group, and this is what's happening in reality. When you call the hospital your MRI specialist does MRIs for people suffering from multiple sclerosis and other conditions. And that's on a Wednesday. If in the future we can, and we'll come back to this debate, who is going to disappear first? Is it the GP or is it the hyper speciality? It's going to be the hyper speciality, in my opinion. Yes. We've been talking about optimizing financial resources and optimizing doctors' times. I think all of these devices are going to make that possible. If you do the same work twice in the same day, you're going to be replaced by software. Somebody said that. We're going to be asking doctors to focus on useful contact, on the appointment with the patient. Now, first of all, this is going to create an awful lot of information and disorder. We'll have to get organized to face that challenge. We're going to have to change the role of the doctor and optimize things. And devices will give us the signal to say when we need to act. So it's going to be difficult to begin with, and we're going to have to get used to it. Pierre Simon, in your missions, in what you're setting up, do you have these kind of fields being fed back from the field? Does everybody see this happening? We're talking about this happy, chappy world. Are there people who say, what do they say? Well, I've been listening to everybody around the table, and I share Philippe Demy's point of view. We've got to come back to the reality in the field today, and I'm saying this again and again. We can't do telemedicine without an information system. Using connected objects, if you don't have an IT system that is shared with patients, it's unrealistic. So what Philippe has been saying is true. We need to structure the healthcare path based on shared IT systems. And only then can we do telemedicine, can we use connected objects, as you were saying, Mr. Regnault, to improve, let's say, the healthcare path and the efficiency of that healthcare. We've got to go back to things that are fundamental, that are basic. But this enthusiasm, I'm sorry, this, aren't we putting the cart before the horse? Putting all of these instruments out there on the market, but we don't really know how to use them. It's a bit like, using the instructions for old video recorders made by the Japanese. Yes, we're in this creative fever at the moment. We've got millions of connected objects for health, 50 billion across the world. This is what we were saying yesterday. Only 350 have been chosen by the authorities. All of that is going to be regulated progressively. The bubble will calm down, and we will move into something that is more reflective of reality. I'd like to come back to the worry, the concern in terms of general medicine, general practitioners. Yes, sorry, and also patricians. So practitioners and patricians, sorry, yes, it really is a challenge. In university hospitals, we often say that hyper-specialization is dangerous for disciplines, and hyper-specialities are dangerous for patients. And that really does reflect the fact that the more we are sophisticated, the more we are specialized, the more transverse approaches do we need. So you've got these different management levels. Who is in the best position to explain this to patients and guide patients along their path than the general practitioner? This appears to me to be fundamental. We need to have this electronic medical record. When I say medical, it has its administrative part, so the identity of the patient, the social data, the medical data. We need to have the care part of that medical record. So if we want medical efficiency, well, we've got to have the right kind of details recorded in the file. We measure that very easily when there are legal problems. What does the judge look for? It's not the medical data as such. It's all of the logistics data for managing the patient. So that's where the challenge lies. You know, the data, consistent data in terms of patient management. That has to be accessible. That kind of information has to be accessible to all healthcare professionals that have anything to do with the patient. And I think that, GP medicine has a primary role to play in this system. And I agree with those who consider that digital technology is going to really underline the role of the general practitioner. But obviously, we have a long way to go for everybody to understand things in that way and to have the right kind of equipment. Olivier, I'd just like to come back to what's been said concerning the healthcare path and patient management. Digital technologies, data influxes, should they not make it possible to share tasks so that we don't have too much information? Is it not going to be necessary for doctors in hospitals and also GPs to have bigger, greater collaboration? Nurses, for example, or other health professionals need to take over a certain number of tasks. This is what we were saying when we were talking to Pierre Simon. The ability that we have, this is what Philippe Daumier was saying as well, to invest in infrastructure. You had a doubt about the use from a professional point of view. But we don't care about the technology itself, right? That's, there's what is good is how we use the technology. So it's the use that a citizen may see, the advantage that a citizen may see in the technology itself, in digital technology, and in the autonomy that this can provide. So it's a question of increasing quality. Economic development will follow on. We want more quality for our citizens. And here we have a real challenge. And this is your professor of medicine speaking. We've been trained for, to focus on the position of the GP. He's the first person that patients go to see, whereas in the future, the GP will only be just one part of the healthcare value chain, whereas today the GP, according to the GP, is an essential link, whereas in the future, patient management will be organized in such a way that the GP will only be one link in the chain, and that chain will be very complex. When you were saying that this first recourse role is going to still be important, well, you've got the role of all of the professionals, nurses, physiotherapists, but also medical and social professionals, the network engineers too, and the patients themselves, of course. Yes, that's the chain, the value chain around the patient. Obviously, the patient is included in that. And the patient, of course, in terms of decisions and choices. So it's really a cultural revelation. This is what a dear friend of mine was saying. The most difficult path in this kind of mutation is the longest path, the 20 centimeters between these two times. So it's a training revolution that we need. It's the same for all healthcare professionals. So this possible collaboration, is it something that, how did you say it, specialists, medical specialists? What was the expression you used? I forgot the term you used. Yes, we're talking about primary care specialists, so that's complicated. It's, we try not to. Well, I talk about family doctors. Yeah, that's okay. That's all right as well.
Okay, we can also talk about patchwork families and family doctors. Anyway, is this sharing of the tasks something that we could imagine? We see this in these new pluridisciplinary health centers. Is this something that people will adopt in a new mindset this idea of the delegation of tasks and sharing of tasks. Well, it seems obvious today, doesn't it, where this will allow doctors to concentrate on their core activity, but it also allows them to carry out acts with high added value with respect to their profession. Yesterday we were talking about MOOCs, and we were saying perhaps it's not even necessary to have 12 years of training for a doctor, and we could train them differently. But without going into that debate, today it's obvious that we need to entrust different tasks to paramedical professionals. They can help us carry out acts that take time for us as doctors. This is already done. It's already been done in Anglo-Saxon countries for many years. 20 years ago, there were already offices organized in the U.S. where the nurse manages the whole first part of the consultation and the post-consultation, and just the reason for the consultation was managed by the doctor. This is something that we need to have enter into our French mindset, and doctors shouldn't be afraid that their profession will be threatened. On the contrary, they'll be able to concentrate on their core activity. That seems obvious to me. Now, in the remaining time, I'd like to focus on a crucial problem, which is the problem of money. I had an experience personally. This was not my own personal experience, but it was an interesting one that I heard of. It was in the real center of France, in a place called Indre, where the first eye doctor is at least 60 kilometers away. And there were doctors who were organizing themselves and who were doing these in-depth eye examinations. The GPs were doing the preliminary eye exam and then sending it off to their ophthalmologist. And this was costing €0. Now, how long will these experiments be able to last with people who are now working for free? Well, I can answer that. Inside the hospital and at the university hospital that I will be managing for another few weeks, all of the experiences that we've carried out with telemedicine were either financed experimentally, and we ran out of the experimental funding, or they were carried out for free. Now, the multiplication of the demands, for example, to interpret X-rays at the hospital in Castelnaudary from us, we're 50 kilometers from Toulouse, etc. All of this added up until the bosses came to see me and said, stop, we're stopping the experiments because the workload is so high that it's no longer compatible with the organization of our planned or unplanned activities. So until we give as precise and robust tariffs to all of these activities, it won't work. I think we shouldn't hide our heads in the sand. The public authorities have to deal with this difficulty, but it's not insurmountable. I think we can succeed. But we need to talk about prices. Now, because we're talking about money, in our university hospital, we've developed an information system that is as open and communicating as possible. And we studied its interoperability to allow us to connect connected objects, interface with all types of software, with IT, well, I call them multiple sockets. I don't know what the real word is. But this could, if you look at the population, in terms of the population, implementing the infrastructures, it would cost just €10 per inhabitant to get the system up and running, between 25 and 27 million for some 200,000 inhabitants. So the cost of healthcare consumption for a local inhabitant is €3,812 per year per inhabitant. And so it's unbelievable that in our country, in 2015, when you see the progression of these irrelevant expenses, and it seems impossible that we can't just assign €10 to each inhabitant to solve these difficulties. I presented a report to the very highest authorities, and they said that it was too ambitious. So this is the reality in the field in 2015. So we have 2 minutes for each of you. Let me just reinforce what you've just said. we asked to have a price for this in June 2011 for this Telecardiology Act. That's why doctors are still working for free. We need this to be taken into account. When a doctor has a face-to-face meeting with the patient, he's paid. When he does these remote consultations via an electronic file, he doesn't make any money. So there's a real issue here. And we asked the question 4 years ago, and we still haven't received an answer. Secondly, very rapidly, one last comment. In the respirator, everyone agreed that we should set up these monitoring systems, and then we had a problem with observance. If the person didn't use or didn't take their treatment, we didn't want to reimburse the treatment that they weren't taking. So that's another whole debate that we're opening up. But there was a problem in terms of observance. Yes, we need to find solutions to the pricing problem posed by telemedicine, but there are solutions. We could mention many of them, and we don't have the time here, but let me react to what Isabelle Vidal was saying yesterday. The tools exist. We have a tool that's ready to receive telemedicine. We've designed this information system for that purpose. Now we need to free up the energies in this country so that we can make progress and move on to the next step. Step by step, yes, but we need to move forward and give some leadership to the people involved. Create tools that are adaptable and appropriate for them. There's no point in creating tools that are too complicated. Now, you helped me come back to earth with respect to this super interesting topic that we've been discussing. We've been talking about things that make us dream, these connected objects, but we need to explain that they have a cost and what are the difficulties. So I thank you all for getting up early this morning to help me make this analysis with you. Thank you very much.